Imagine Maria, a 29-year-old woman living with type 1 diabetes. She dreams of becoming a mother, but she's scared. She has heard stories of miscarriages, birth defects, and difficult deliveries. Her relatives tell her, "Don't get pregnant. Diabetes will ruin everything." But is that true? Modern medicine says something different. With proper planning and care, most women with diabetes can have healthy pregnancies and healthy babies. The latest recommendations from the European Society of Endocrinology and Endocrine Society give clear guidance on how to do it. Today, we will explain these guidelines in simple words. No confusing medical jargon. No fear. Just knowledge. Because knowledge saves lives. So stay with me until the end. I promise you will understand everything. What is pre-existing diabetes in pregnancy? Let's start with basics. Pre-existing diabetes means a woman already has diabetes before she becomes pregnant. This is different from gestational diabetes, diabetes that develops during pregnancy. In type 1 diabetes, body does not produce insulin. In type 2 diabetes, body cannot use insulin properly. Both type 1 and type 2 diabetes can exist before pregnancy. A woman named Sarah had type 2 diabetes for 5 years. She controlled it with tablets. When she became pregnant, she thought everything would be fine. But her blood sugar was high in early pregnancy. That early period is very important because the baby's organs are forming. High sugar at that time can cause problems. That is why pre-existing diabetes needs special care. Basic science. Let's understand insulin and glucose. What is insulin? Insulin is a hormone made by the pancreas. Its job is to allow sugar from food to enter cells, provide energy, keep blood sugar normal. Think of insulin like a key. The key opens the door of the cell. Sugar enters and gives energy. If the key is missing like type 1 diabetes or broken like in type 2 diabetes, sugar stays in the blood. Blood sugar rises. That is diabetes. What is hyperglycemia? Hyperglycemia means high blood sugar. High sugar is harmful during pregnancy because it crosses the placenta. It reaches the baby. It may cause the baby to grow too large. It increases risk of complications. What is glycemic control? Glycemic control means keeping blood sugar in target range. It is the foundation of a healthy pregnancy for women with diabetes. Pre-existing diabetes versus gestational diabetes. Many people confuse these two conditions. Let's clear it up. Pre-existing diabetes is that diabetes already exists before pregnancy. The woman may have type 1 or type 2 diabetes. Blood sugar problems are present even before conception. Requires ongoing management throughout pregnancy. Example, Sarah had type 2 diabetes for years. When she became pregnant, she continued to manage her diabetes. That is pre-existing diabetes. Gestational diabetes is diabetes that develops during pregnancy, usually appears in the second or third trimester, often goes away after delivery, still requires treatment because it can harm mother and baby. A woman with normal sugar before pregnancy develops high blood sugar at 24 weeks. That is gestational diabetes. Why the difference matters. The timing of diabetes changes risk. Pre-existing diabetes can affect the baby in very early pregnancy when organs are forming. Gestational diabetes usually affects growth later in pregnancy. Both need medical care, but strategies may differ. Investigation differences. For pre-existing diabetes, HbA1c before and during pregnancy. Continuous glucose monitoring. Medication review before conception. For gestational diabetes, oral glucose tolerance test during pregnancy. Blood sugar monitoring after diagnosis. Treatment. Differences. Pre-existing diabetes, insulin often required. Preconception counseling. Medication adjustment before pregnancy. Gestational diabetes measures are diet and exercise first. Insulin if needed. Usually resolves after delivery. Prevention message is gestational diabetes cannot always be prevented, but risks can be reduced by healthy weight, balanced diet, regular checkups. Pre-existing diabetes requires planning before pregnancy for best outcomes. A woman named Angela developed diabetes during pregnancy. After delivery, her sugar returned to normal. That was gestational diabetes. Another woman, Julia, had diabetes before pregnancy. She continued treatment throughout pregnancy. That was pre-existing diabetes. Both needed care, but their conditions were different. Key takeaway is: pre-existing diabetes is before pregnancy. Gestational diabetes is during pregnancy. Both require medical attention. Proper care improves outcomes. Why does diabetes affect pregnancy? Let me tell you a short story. A mother named Farah had uncontrolled diabetes when she became pregnant. She did not know she was pregnant until 6 weeks had passed. By then, important organs of the baby were forming. High sugar during that time increased risk of birth defects. This is not to scare you. It is to explain why planning and early control are important. Science behind it. During the first 6-8 weeks, heart, brain, spine, limbs all begin to develop. High glucose can interfere with this process. That is why guidelines emphasize preconception care means before pregnancy. Good glycemic control, medical counseling. Investigations means tests you need. Let's simplify medical tests. 1. HbA1c test. This test shows average blood sugar of the last 2 to 3 months during pregnancy. Target is ideally below 6.0%, as close to normal as possible. Alarming values when HbA1c is above 6.5% before or during pregnancy indicates poor sugar control. Higher risk of complications. Why it matters. Gives overall picture. Helps doctors plan treatment. Lower A1c reduces complications. Guidelines recommend HbA1c as close to normal as possible before pregnancy. Self-monitoring of blood glucose. This means checking blood sugar at home using a small device. You prick your finger, and the device shows the reading. It is important because it gives daily information, helps adjust diet and insulin, prevents high or low sugar. 3. Continuous glucose monitoring. It is a modern technology. A small sensor measures glucose all day. Benefits are real-time data, alerts for high or low sugar, helpful for type 1 diabetes. Guidelines recommend continuous glucose monitoring in selected women, especially with type 1 diabetes. Fasting blood glucose. This is blood sugar after not eating for at least 8 hours. Normal or pregnancy target is 70 to 95 mg/dl, alarming when it is 95 mg/dl or higher repeatedly, suggests poor control. Postprandial blood glucose is after meals. Blood sugar is checked 1 or 2 hours after eating. Targets in pregnancy is 1 hour after meal is below 140 mg/dl, 2 hour after meal is below 120 mg/dl. Alarming is when after. 1 hour is 140 mg/dl or higher and after. 2 hour is 120 mg/dl or higher. These values increase risk of fetal overgrowth and complications. Oral glucose tolerance test. Used to diagnose diabetes and gestational diabetes. For a 75-gram OGTT, it is common standard. Diagnosis of gestational diabetes: if any of these are high, fasting is equal or higher than 92 mg/dl. After 1 hour is equal or greater than 180 mg/dl, and after 2 hour more than 153 mg/dl. One abnormal value may require medical follow-up. Diet and lifestyle. Simple rule are: food is medicine. During pregnancy with diabetes, diet becomes even more important. The golden rules are: eat regular meals, include whole grains, eat vegetables, choose lean protein, avoid sugary drinks. Think of it like fuel for a car. Good fuel keeps the engine running smoothly. Bad fuel causes problems. Common mistakes are skipping meals, eating too much sugar, extreme dieting. Balance is the key. A woman named Nadia stopped eating carbohydrates completely because she feared high sugar, but her body became weak. Her blood sugar actually became unstable. Lesson: carbohydrates are not the enemy. Quality and quantity matter. Medications: what is safe and what is not. Let's talk about medicines. Insulin, the gold standard. Insulin is safe during pregnancy. It controls blood sugar effectively. Women with type 1 diabetes always need insulin. Women with type 2 diabetes may need it during pregnancy. Tablets and other drugs. Some diabetes tablets are not recommended in pregnancy. Examples are GLP-1 receptor agonists. It must be stopped before conception. Certain oral medications. Why? Because safety data in pregnancy is limited. Guidelines prioritize insulin. Important message is, never stop or change medicines without medical advice. Always consult your doctor. New technologies is hybrid closed-loop systems. Technology is changing diabetes care. A hybrid closed-loop system combines insulin pump and glucose sensor, automatically adjusts insulin, helps maintain stable sugar. It is especially useful for type 1 diabetes. Guidelines encourage its use when available. Preconception care is before pregnancy. This is one of the most important messages. Preconception care means preparing for pregnancy. Steps include blood sugar optimization, medication review, folic acid supplementation, health counseling. Why it matters. Most birth defects occur in early pregnancy. Good preparation reduces risk. A woman named Zainab planned her pregnancy. She controlled her sugar. She visited her doctor. Her pregnancy was healthy. Planning made the difference. Delivery and newborn care. Women with diabetes may need special delivery planning. Sometimes early delivery is recommended. Why? To reduce risk of complications. Newborn care is also important. Babies of diabetic mothers may need blood sugar monitoring, extra feeding support. Medical observation. Most babies do well with proper care. Prevention and long-term health. Diabetes is manageable. Prevention tips are regular exercise, healthy diet, weight control, medical follow-up. These steps improve overall health and pregnancy outcomes. Diabetes is not a barrier to motherhood. With knowledge and medical care is. Healthy pregnancies are possible. Risks can be reduced. Families can thrive. The key is preparation and teamwork between patient and doctor. If you found this information helpful, like this video. Subscribe for more medical education. Share it with someone who may need it. Knowledge saves lives. Let's spread awareness. Pregnancy with diabetes requires care, but it is not impossible. Modern guidelines from the Endocrine Society and other expert bodies provide clear strategies. With planning, monitoring, and treatment, healthy mothers and healthy babies are achievable. Thank you for watching. Take care of your health.